So just know about that. We are also muting all the participants except for the people who are presenting. So you can use the chat to send questions. So the chat is in the bottom of the screen. I'm sure all of you are becoming complete professionals about Zoom use by now. In the future, if you are acknowledging the presenters and the entities that have cited the data in case you talk about COVID-19 and MS, make sure that you acknowledge the people who have shared kindly their data. So the goal of the meeting is to have an open and timely discussion on the issue of COVID-19 and MS and related disorders, and share information that becomes available. We are really deeply indebted to the people who have joined the meeting and have shared their information over the past 2 months, because it has been really an amazing experience of collaboration, generosity, and we all have learned so much through these meetings. So I'm not sure if Gavin, are you on?
Yes, I'm on.
You're on. So do you want, thank you for joining. So Dr. Giovannoni is based in London, and you can share your slides, you can share your screen directly if you want.
Okay, the presentation. Can you see it, Emmanuel? Is it live?
Yeah, so we had it disappear. So I think it's loading. So
yeah, it's loading. Okay, so should I go? How much time have I got, Emmanuel? 15
yes.
minutes?
So so you have 10-12 minutes, and I know you wanted to mention some of the data that had been presented in the past about the use of anti-CD20 agents and the number of COVID-19 patients. But as Jan Hillert is on the call and planning to present the Swedish data, I think we'll have an update just after you about that.
Okay, sure. So I do have quite a few disclosures. I'll send you my slides. So you're aware of Jan presenting this last week, and I couldn't resist just doing a chi-square to show that there were more patients with rituximab getting COVID than the other DMTs. But in terms of hospitalization from Jan's data last week, it didn't appear that anti-CD20 was associated with more severe disease based on the raw data. The reason why I was asked is because Roche got their data published as a correspondence in MSARDS early this week. Basically, they reported the first 100 cases that came via their pharmacovigilance reporting system that had been on ocrelizumab and developed COVID-19. And as you can see, 26% of these were classed as serious, those requiring a hospital admission, and only 5% were critical, those would be on ventilators. Now, this data is clearly unadjusted, and there's lots of biases in it. Probably patients that get reported are much more likely to be admitted to hospital, much more likely to have more severe disease and actually be tested. So I think overall these figures are kind of in line with most population-based figures of about 20% getting serious disease, with about 5% needing ITU. So I think this is just another data set, and the data is what it is, showing there is no obvious big signal that getting COVID-19 on an anti-CD20 therapy is associated with more severe disease. So this is a spectrum of COVID-19. So going from asymptomatic through mild, moderate, severe, and then death. And so the question that we can't really answer is, does being on an anti-CD20 therapy increase your chance of being infected? I suspect unlikely, okay? Does it increase the chances of becoming symptomatic? And that's possibly based on the Swedish rituximab data, and I think we need more data to be confident of that. In other words, is it more likely to allow viral replication, for example, more likely to get higher viral loads? And I think we have to keep that question open, that there may be a slightly higher incidence based on the rituximab data, that people with COVID-19, people on rituximab are more likely to be exposed and get symptomatic infection. Now, you could argue that people on rituximab in the Swedish data set are younger, more mobile. There's a whole lot of reasons. And the Swedish situation that Jan will talk to is very different to the rest of the country. They've got only a voluntary lockdown, in the sense that social distancing is relied on by the population, not enforced. And does anti-CD20 therapy take moderate to mild to more severe and increased death? And I think that's also based on the current data set, unlikely both for rituximab and ocrelizumab. I think the question about whether or not anti-CD20 therapy actually improves or reduces your chance of getting severe disease is still an open question. And there is a possibility, simply because when you look at the post-mortem material of people dying of ARDS, the lungs actually on the left-hand side here, you can see a lot of pulmonary hemorrhage, and on the right-hand side you can see immunoglobulin and complement activation. So there is this theory that if you make an immune response and the immunoglobulin response happens and you get complement activation, you get worse disease. And that's kind of one of the reasons why there's some pushes to try inhibitors of complement activation to prevent adult respiratory distress syndrome. And so the hypothesis that I've been discussing with you tonight, or putting out, is by being on anti-CD20 therapy, do you blunt the antibody response that's induced by the coronavirus, and therefore do you lessen the chances of getting severe adult respiratory distress syndrome? One of the clues overall has come from the ITU data in the UK. This is our intensive care order data. It's real-time data, and this is now quite old. But when you actually look at the proportion of people in the UK admitted to intensive care unit with severe COVID-19, a small percentage were on immunosuppressive therapies, only 2.3%, compared to 8.5, almost 4 times higher in terms of other viral pneumonias collected between 2017 and 19. So the interpretation of this data is that less people on immunosuppression are getting admitted with COVID-19 than you'd expect based on other viral pneumonias. And that's an interesting thing, because I think this is a message that may be coming through on the rheumatology data, on the transplant data sets as well, that patients that are on immunosuppressive therapies, I'm talking about mild immunosuppressive therapies, appear to be doing much better than you'd expect based on this being a viral infection. So there is potentially an advantage on being on a mild to moderate immunosuppression if you get COVID-19. I think what's clear is you don't need B cells to recover from the infection. So these, how many swallows does it take to make a summer? Well, these 2 cases are really, really important. So the 2 cases of X-linked agammaglobulinemia. So these people don't have any B cells. They live on IVIG, so replacement therapy, and you have to assume that the IVIG they're getting has got no anti-coronavirus antibody in it. Both these patients got COVID-19 and made a spontaneous recovery, which means you do not need B cells to recover from the viral infection caused by coronavirus. Okay. Now, what controls the coronavirus? So we know from SARS coronavirus 1 that the initial immune response is driven by innate cells, mainly neutrophils and macrophages, and you really do need cytotoxic CD8 T lymphocytes to clear the virus. And that may explain why therapies that suppress that deplete T cells in great numbers, like anti-thymocyte globulin, ATG, has been shown with quite a poor prognosis in the transplant. In the transplant field, it's only the ATG-treated patients that do really badly. They've got about a 30-something% mortality. People on other immunotherapies did much better. Obviously, in terms of re-exposure and secondary infection, then antibody proteins, in terms of antibodies against their spike protein, may be important in terms of neutralization. So I think we have to say for primary infection, you don't need B cells. Also, when you look at what happens to the immune system, this is a case study from Australia. By the time the antibody responses come back, develop, be it I'm just going to try and point, be it antibody-producing cells, okay, or antibody production, they occur after the patients are recovering and they become swab negative. So I think the antibody responses, they do occur, but they're not really responsible for clearing of the virus. And this is an active infection model using primates, two monkeys infected with the corona type 2 virus. Again, during the period of time where the antibodies develop, the animals are ready to get the virus. So a primate model showing you that clearing of the virus is not linked to antibody production. So this so I think all this supports the basic science, the pathology studies, that you don't need B cells and immunoglobulin to clear the virus. It may be damaging in terms of the adult respiratory distress syndrome. But the point about it is our community is very worried about what do we do when you get when a vaccine becomes available. And this is like the epidemiology in one slide. It took me about 2 hours to draw this thing, trying to get all there. But I think the important message is we're relying on vaccine come along to cut off the tail of this epidemic. And so if we're relying on a vaccine to make our patients immune, the therapies they're on are really, really important. And I just want to point out in terms of the anti-CD20 complex, when you look at what happens in lymph nodes, you can see that this is a lymph node of a patient on rituximab. They don't have germinal centers, okay? They don't have any. They have T cells, but if you look on the control, you see these little brown spots. Those are germinal centers. And in the lymph node of an anti-CD20 treated patient, there are no germinal centers. So the point I want to make is that you need germinal centers for class switching, affinity maturation, for making good quality, high affinity antibodies, potentially neutralizing ones. And I would expect that we're not going to see this in people with B cell on anti-CD20 therapy. And we know this from the vaccine studies. This is the Roche data showing you that people on anti-ocrelizumab have blunted antibody responses to both recall and novel antigens. And I think the one that's really informative is the pneumococcal vaccine. They really do have poor responses to pneumococcal vaccine. And the thing about pneumococcal vaccine, it's a polysaccharide vaccine. And so for antibody responses against polysaccharides and glycoproteins, you really do need a good functional germinal center. Okay. And the reason why you need a good functional germinal center is because the spike protein of coronavirus is heavily, heavily glycosylated. And it's obviously glycosylated for a reason. That's part of its immune evasion technique. It helps evade antibodies, etc. So I suspect if the vaccine that emerges is the glycosylated version of the spike protein, which is what some of the pharma companies are developing, being on an anti-CD20 therapy is not going to be a good drug to be on if you want to have an antibody response. So the question then is, can you stop anti-CD20 and wait for your B cells to come back? And this is the phase 2 ocrelizumab trial extension program, and you can see in the top left panel here, this is up to 18 months of ocrelizumab stopped, and you can see it takes 12 plus months to get a significant return of your B cell numbers. So I suspect if you're going to want patients to respond to a component glycosylated vaccine, we're going to have to probably stop anti-CD20 for a good 6 to 12 months prior to vaccinating them. So they have enough naive B cells from their bone marrow to mount a good response to the vaccine. The other problem is a lot of people are saying, well, this is how we should use anti-CD20 therapy, because based on the phase 2 data, these patients still remain in remission in terms of relapses and MRI activity. And I want to argue that we shouldn't be fooled by the relapses and MRI activity. Because I think there's overwhelming data that it isn't a disease. So this is actually a really important message. If I can get this across today, I'll be very happy. When you look at treatment trials, relapses and MRI activity only predict outcome in the treated group. And so this is just the 15-year follow-up of the AVENEX pivotal trial. And you can see if you had GAD-enhancing lesions or relapses on AVENEX, you are much more likely to end up in the worst quartile compared to patients who didn't have that activity. Whereas in the placebo arm, there was no prediction. And if you know anything about Prentice criteria for a surrogate endpoint, this means that by medical philosophical deduction, MS cannot be GAD-enhancing lesions, UTT lesion relapses. That's probably in response to what's causing the disease. And so, and we now know from other studies that most progression or worsening of the disease This is natalizumab data, occurs independent of relapses. So this is the peer publication from the post-marketing surveillance data. 2/3 of the progressions were in patients who were independent of relapses. And actually, when you look at the peer data from ocrelizumab OPERA studies, you can see 88% of the worsening that occurred on ocrelizumab, this is to confirm disability progression using a composite, was independent of relapses. So the real MS has to be the progression. It can't be the relapses and MRI activity on top. And why is this important? Because we got another message. So those of you who were at ECTRIMS last year would have seen this presentation of the next generation completely humanized anti-CD20 of ofatumumab versus teriflunomide. You can see how remarkable ofatumumab is at suppressing relapses and MRI activity relative to teriflunomide. We've got figures in 55% for relapses and close to 95% for MRI activity. But when you go to the things that are really, really important in terms of MS, which is progression and brain atrophy, you can see the treatment effect was really not that great relative to teriflunomide or ofatumumab. And when you re-baseline brain volume at 12 months, there's really no difference between anti-CD20 therapy and teriflunomide in reducing brain end organ damage, brain volume loss in year 2. So I think this is another example of this dissociation between focal inflammatory activity and what's I think driving the real MS. So there's clearly ceiling and floor effects, and this particular data was presented by Steve Hauser at last year's American Academy. I wish it was published. This is just dividing up the population of patients on ocrelizumab in the 2 programs, the relapsing remitting program and the primary progressive, based on the amount of exposure they had to anti-CD20. This is blood levels. And you can see when it comes to looking at GAD-enhancing lesions or new T2 lesions, there was no dose effect between those in the lowest quartile versus the highest quartile. Absolutely. So you'd argue based on this MRI data, that it doesn't really matter what dose of ocrelizumab you get the same response on MRI. And similarly, when you look at relapses, no difference. The relapse rates across these quartiles of exposure are identical. This is what I call the ceiling effect on relapses and MRI activity. But when you look at disability progression, there's a clear ladder. So those with the highest exposure rates get the most suppression of disease progression. And so, well, how real is this? Well, we saw exactly the same thing in the Oratoria data set. It's also the highest exposed population. The more ocrelizumab they got based on body weight and body size, the better the treatment effect on disability progression. So this is telling us that we possibly need high doses of anti-CD20 therapy, and where it works is a debate. I suspect we may need CNS penetration or maybe deep tissue. The hypotheses are Epstein-Barr virus in the peripheral deep tissue compartment, or possibly the intrathecal B-cell response. So this is why we're trying to stimulate Roche Genentech to do a trial comparing a high double dose versus single dose, and to explore where this is happening. Is it occurring in the central nervous system or in the periphery? So I personally don't think we've sorted out the dose of anti-CD20 therapy in terms of tackling the real MS. I think we're hitting a ceiling effect when it comes to suppressing focal inflammatory lesions, but don't be lulled into the fact that because you've got people that are relapse and MRI activity free, that you've got the disease under control. I think there's something else what I call smoldering. So I would make the argument that ocrelizumab may be more effective than rituximab and ofatumumab, because ocrelizumab is clearly more potent than rituximab in terms of B-cell depletion and the repopulation kinetics are much lower. And that may be important because ofatumumab is going to come out with the claim that you can reconstitute your B-cell compartment even quicker. And that may be the Achilles heel. Yeah, sure, it's effective at suppressing relapse and MRI activity, but is it going to get to the real MS? Is it going to get to that brain volume loss? And we saw ofatumumab was no better than teriflunomide in reducing brain volume loss in year 2. So to conclude then, the questions we need to answer are the anti-SARS coronavirus 2 antibodies protective against reinfection? We don't know that yet, and the WHO has been absolutely categorical. We have no idea how long immunity lasts. When it comes to the antibody response on an anti-CD20s and other DMTs, are there quantitative differences? And I suspect there may be. I suspect we may find that people on anti-CD20 therapies that haven't got B cell reconstitution may make lower titers, and they may have qualitative differences. They may have reduced class switching to IgG and IgA, and they may not have neutralizing antibodies. So until we answer these questions, we're going to have to be we need to answer those questions before we consider what our vaccine or vaccine readiness strategy is. And then which vaccine will be effective, that's up to the trials that are running now. There are over 70, according to WHO, there are over 70 vaccines in clinical development. So it's a very busy time. I try and keep things up to date on a website I've created around COVID-19. If you want to go onto it, my table now is in version 5, and it's now becoming a checkerboard, and it's got lots of information, and there is a column that's dedicated to vaccine readiness. Questions? Thank you.
Thank you, Gavin, for your talk. So I do not see any questions in the chat so far. So questions come as we go along. So maybe Jan, so Gavin, please stop sharing your screen. And then maybe Jan can show us the updated information from the Swedish registry.
I can't even see I don't know, there it is. Okay, stop sharing. Okay.
Very good. Thank you. So, Dr. Hillard?
Yes, I'm here. Just a moment.
Looking forward to the Swedish update.
Okay, so do you see my screen now?
Yes, we do.
Okay, so I put it on slideshow. Just a moment. Okay, so thank you, Manuel and Fabienne, for having me present once more. And thank you, Gavin, for paying attention to our data from last week. I must say it reached also the community of Swedish MS patients, and in a way that I had not clearly anticipated, but no harm. I think this is an interesting area of information that we need to be very open about. So this is just fine to me. So I just wanted to update you on what the figures are for this week. So we have now 74 MS patients in the COVID registry. Of those, 16 are hospitalized and 8 have experienced a stay in the ICU. As you see here, they are those with a severe disease have been slightly older than the overall patients in the registry with a COVID infection, but they're quite comparable with the average patient in the registry. There is still a female preponderance also amongst those identified and having signs of a severe disease. There's an overrepresentation of progressive patients, which fits with the expectation, as well as with people with more disabilities. Maybe there is a signal here with some people or more people on DMTs among the hospitalized and ICU cared. And then what is the focus of interest, of course, is that whereas 33%, which is in itself a huge proportion, of course, of MS patients in the country treated with rituximab, there seems to be an overrepresentation amongst those identified with a COVID infection, hospitalized, and also in ICU. But as you see here, it's 8 patients, and these are small numbers, very sensitive to random effects, of course. So the first question we asked, of course, was, is the overrepresentation of rituximab treated patients due to those people being more disabled or older? No, it's not. They are younger, they are less disabled, so that's not the explanation. There needs to be some other explanation. Of course, this can be a property of rituximab, a class effect or a specific effect of rituximab itself, of course. But if you look here on natalizumab, so there are 5 times as many people in our registry on rituximab as on natalizumab. But if you multiply these figures by 5, you will almost reach the figures we have on rituximab. And this to me signifies that maybe what we're looking at here is actually an ascertainment bias. So in the period of COVID, of course, each and every department needs to contact people on rituximab. We need to reschedule their infusions or ask whether they want to have their infusions rescheduled. So we're very likely to record their possible affliction with COVID-19. So it's a very reasonable mechanism, at least. So the comments I have today is to some parts the same and then to some parts different. So yes, there is an overrepresentation of rituximab treated patients amongst those in our registry with COVID-19. We do have a very special treatment situation with 33% of all MS patients on anti-CD20 treatment. But the risks, though, of having a severe disease are still very low. So it's 1 in 1,000 MS patients in the country that have been hospitalized due to COVID-19. Amongst those of rituximab, the figure could be twice as big, but it's no more than, it doesn't appear to be more than a double effect at this stage, though. Our data are descriptive. We haven't yet performed any kind of formal significance testing. We have too few patients to deal with confounders and biases. Ascertainment bias still is a very likely contributing factor, as is the higher proportion of patients in Stockholm being treated with rituximab. And Stockholm is the hotspot in the country for COVID infection. So far we have no possibility of coming to a conclusion. We are in the process of doing further analysis. We're comparing to the national risk of ending up hospitalized, the national risk of ending up in the ICU context. And we still don't know to what extent our data are complete or to what extent they are incomplete, I should say. So yes, there could still be a signal here. By no means we can say there is no signal. There may be other explanations, and I will be very happy to keep you updated as we go along. And therefore, it's vital to me to present these data to this community because we need data from other departments around the world in order to know whether this is a bias, whether this is a pattern, or whether this is really something that we need to take into consideration. Okay, I think I'll stop here. Thank you.
Thank you very much, Jan. I agree that the places that will be able to have either population-based analysis like in Sweden or places like in Italy where they are able to do a case control study. I know they are in the process of trying to adjust their analysis for the use of different treatments according to the sites will be very informative because we could make we could make some conclusions that are maybe not really real. So thank you very much for the presentation. So we'll take a few questions and then we'll continue with Georgina. So the first question that I have here is, how do you weigh risks and benefits of the dose related increased infection risk seen by the Swedish rituximab registry with the benefit of higher dose on disease progression, especially in the setting of the pandemic? So I guess that's a question for Gavin. Gavin, if you're still with us, yeah.
Yeah, still with you. So my interpretation of the data so far is that people on anti-CD20 therapies, ocrelizumab, don't appear to be at a much greater risk of in COVID or severe COVID. So we've actually just gone back to dosing redosing according to standard protocol. And we will hopefully be able to restart our trial program, which includes anti-CD20s. And if a vaccine doesn't emerge, I'm not sure a vaccine will emerge, then we will have to address vaccine readiness in the future, to be honest with you. I don't think we should be delaying dosing or adjusting doses at the moment, expecting a vaccine to be around soon. So that's our current practice. The only Europe we're not giving according to routine is alemtuzumab, simply because it causes profound T cell depletion that we have to shield those patients for 3 months probably, and also we got problems getting 5 days of infusion. So alemtuzumab is the only one we put on, and HSCT. Those are the 2 we put on hold, but we are now going back to our routine treatment for that agents.
So another question for you, Gavin. Do you think anti-B cell treatment must be for prolonged periods?
No, I don't. I actually think we need to understand the biology of it. One of the theories is that it's an anti-B drug. So my interpretation is we have to be pretty aggressive up front in terms of very deep B cell purging, as like an induction type process, and then probably don't need a lot of. So use it as an induction maintenance, and I suspect we will be able to maintain people very well with a drug like teriflunomide. And so one of the trials I've been wanting to do, and I've never been able to get anybody interested in it, is induction with anti-CD20 and maintain with a drug like teriflunomide.
Okay, and so I'll go to a question for Jan. So can you comment on the dosing regimen that are typical for rituximab in the Swedish patients?
Yes, certainly. Thank you, Ellen, for that question. The typical treatment these days will be 500 milligrams every 6 months. So we've gone from starting with the full gram twice and then every 6 months, but we've come to typically just give 500 milligrams even for the first time, and then every 6 months. And then after like 2 years, we follow the B cells, and it's almost always possible to extend the interval to 9 months, and then the next time to every 12 months. So in that respect, and I can referring to Gavin's thoughts about the treatment regimen for ocrelizumab, we're giving much lower bioequivalent dosages in Sweden, much lower.
Yeah. So I mean, the point I was trying to make, Jan, is that I think we've been fooled by the impact of CD20 therapies on relapse and hemorrhagic. They're very effective, but not really getting on top of the aggressive disease. Maybe look at the patients that have been on these treatments long term. No, we're not stopping the progression. It's actually in the trial data. It's in the ocrelizumab data set. In top of.
Okay, so there's a few more questions, but I'd like to move on to have Georgina present some of the neurological complications that have been seen with COVID-19 from a neurological standpoint. So Georgina is based at the University of Vall d'Hebron in Barcelona.
Hi, thank you, Ellen. Thank you, Emmanuel, and hello, everybody. Can you see my slides now?
Yes. Okay, so this topic came up about 2 weeks ago in one of the previous calls, and we just want to give a little overview of what we can expect as of neurological involvement in COVID-19. And also because of a question that I think it was Bianca Weinstock-Gutman who posted it, and that call, I will just make a presentation about interleukin-6 and B cells. So
we know in general that there are some case series and cohorts listing all the neurological symptoms, and probably the first one was this study from China with 214 patients. These are the neurological symptoms that they included, and as you can see, they're quite variable, and they could mean anything, even in the case of dizziness or headache, for example. And then you have proper diseases like stroke in this case. So one of the things, it's very descriptive, so we cannot really make many conclusions about it, but one of the things that they do say is that around 36% of these patients had neurological symptoms, but mostly that they were more likely to develop them if they had a severe disease. So there's another study here in the US, and it was also done in this case in critically ill patients. So you can see here that in this case, it was 58 patients in the ICU. All of them had developed ARDS. And one of the things that it's interesting here is also that in some of the cases, they do have a brain MRI due to unexplained encephalopathic features and not necessarily with focal signs. And some of the findings that they had were leptomeningeal enhancement in a few of the patients, perfusion abnormalities also, and in a few cases also cerebral ischemic stroke, even though they didn't have any focal signs. And one interesting thing, because we're always wondering whether the virus has the capacity to invade the central nervous system, is that there was CSF testing for SARS-CoV-2 in 7 patients, and all of them turned negative. This is, of course, a very small numbers, but this is information that we had so far. And in general, what we have to say about these very descriptive studies is that data are lacking to determine which features could be due to the critical illness related encephalopathy, whether there's something related to the cytokine storm, or whether this also has to do with the effect of withdrawal of medication or being in the ICU in many of these cases, or whether these findings could be specific to the proper infection. So there are several mechanisms that could be involved in the neurological manifestations of in COVID. Probably most of them have to do with encephalopathy that is related to the critically ill patient or with severe respiratory symptoms. Then there's the possibility of having central nervous system infections. We have had maybe 1 or 2 cases published. We have seen them published in the literature in which they could be the case, but fortunately doesn't seem to be very common. There are some other cases that are popping up now more often, and that are the immune-mediated syndromes, mostly Guillain-Barré syndromes, and also cranial nerve involvement mostly, at least in the Spanish series. And there are also neurological complications that can arise from the cytokine release syndrome. There's also one case that was in one of the radiological journals that maybe everybody's familiar with. And there are also, of course, cerebrovascular complications that could be related to the cytokine release syndrome, maybe, and some neuromuscular complications, mostly myalgia, but we have seen published several cases of rhabdomyolysis as well. One of the things that other neurologists who were interconsultating at our center were mentioning that myalgias were very common, or also myopathy, but they were not really sure whether it was related directly to the disease or mostly to critically ill patients. It's then in the ICU with sedation and other treatments as well. And one of the things that why we have to see this is that because we have to be ready as neurologists, we could be redeployed to COVID-19 teams or receive COVID-19 related interconsultation requests. And that was the case in our experience in the hospital, which became, Bayebron Hospital became a COVID hospital. And from the SEMCAT team, there are 5 of us ended up in COVID teams at some point during a month. So this could be different, depends on the reality or the stage of the pandemic in every country and every location, of course, but this could happen. So we need to know this neurological symptoms could evolve. But we also have to put things into context. And here I will show you a little bit of the Spanish experience. We also have a Spanish registry of neurological manifestations associated to COVID-19. And there was a publication from data from mid-March to mid-April, in which there were 92 cases with 131 neurological complications. And okay, this is in Spanish, but I think it's easy to see that the most common symptoms were probably just the confusion that could be related to encephalopathy, stroke, and then as more general symptoms, maybe anosmia or hyposmia and headache, which might not be as worrisome as what we can see with stroke, for example. And then there were other symptoms that didn't seem to be very common. The last update that's available, but I cannot show you the data because it's embargoed, is of last week. And it seems to be that there are not that many new cases being added. So right now there are 179 cases, and the proportion of neurological manifestations is more or less the same as you see in this table. And then we have to take into account how many cases we have in total. So if there are only 179 cases, and we have a total confirmed cases in Spain of 232,000, then the percentage of neurological involvement is really, really low. Of course, there could be underreported cases here, but we also have the same situation when counting the confirmed cases. And if we also take into account the recent study that was about serologies in Spain, in which now the estimated people who had been exposed to the virus is over 2,300,000 patients, then the neurological cases that you might see are not really very high. So this is for what we know of the neurological manifestations with COVID-19. And then I just wanted to make a short note on another comment that we had in one of the calls at the beginning of May. One of the information that Dr. Heinz Mindel gave us about B cells and IL-6 is that in patients treated with B cell depleting therapies, there were really no changes in IL-6 levels. But then the reverse question that we didn't have much time to explore was this one. How relevant is, on the other side, interleukin-6 for B cells? And then what we know is the following. We know that under an infection, in this case COVID-19, it will be mostly macrophages and endothelial cells that will produce IL-6. They're not the only cells. B cells can also produce them, but they're probably not the most important ones at this stage in this disease. But the thing is that interleukin-6 can also, among other functions, promote Ig production and also T cell differentiation. And it has been showed, at least in some diseases, that the persistent or dysregulated IL-6 production can produce, among other things, autoimmunity or autoantibodies. So one of the questions that could arise is whether IL-6 produced during COVID-19 infection upregulate memory B cells functions in patients with MS or NMOSD, and whether besides just developing the cytokine release syndrome, can they also show some worsening or also relapses of the disease at this stage if they are not being treated with, for example, B cell depleting therapies. We also have to take into account that Ig production, for example, is not solely responsible, IL-6 is not solely responsible for Ig production. It can also be done by IL-21 and other cytokines. So there's just food for thought. And there's still, I think the answer might be a bit more complex than what we can think right now. So I think I'll stop here and I'll be glad to take any questions.
Thank you, Georgina. So what we'll do, we'll have Seth maybe do the last scheduled presentation, and then we'll go through the questions we have that we've not had a chance to address yet. Thank you. So Seth, are you still around?
Yep, I'm here. Thank you so much.
Excellent. So grab the screen and share the information from Columbia and Pittsburgh.
Okay. Can everyone hear me?
Yes, very well.
Okay, great. So first of all, thank you to the organizers for having us speak about our ongoing study. So this is called the MS RECOV study. It stands for MS Resilience Against COVID-19. And we launched it at the beginning of April. As many of you know, Columbia is in New York City, and we were hit really hard with the COVID-19. And when we locked down, we decided to create a prospective longitudinal study, really trying to interrogate patients' experience during the COVID-19 pandemic, with the goal of trying to understand risk factors for COVID-19, but also trying to understand how the pandemic is impacting their lives. Here are my disclosures. So the objectives of our ongoing study is really to complement existing national and international registries. So this is not a physician-reported or a healthcare professional-reported registry. This is a patient-reported. So we use REDCap to capture, we use surveys and we capture patient reports on REDCap. And we wanted to identify risk factors for developing manifestations of COVID-19 and assess how the pandemic is impacting management's neurological and psychosocial outcomes. And finally, ultimately, you know, the thing that we care a lot about is how when the vaccine becomes available, how we can study the impact of the vaccine and the impact of that prior exposure with serology. So having a database of patients, both symptomatic and asymptomatic, is helpful to look at among our MS group who has been exposed or not exposed. So I mentioned that this is a prospective study. It's planned to be 1 year. And at this point, it's been about 6 weeks since we launched the study. And our target populations are predominantly persons with MS and related disorders, but we've also recruited a asymptomatic reference group. We recruited people predominantly in the early phase at Columbia and Pittsburgh, but this is a collaborative study with 10 academic centers. I'll show you the centers later, but it's predominantly in Northeast United States, but we also are collaborating with Toronto. And the recruitment strategy, I mean, we recruited people with our newsletters, through our institutional research registries, and we have spoken to and communicated with multiple MS centers that are launching their own sites. And the questionnaires, as I mentioned, were really to try to ascertain exposure and symptoms of SARS-CoV-2, the impact on neurological disease and treatment, and some of the social, psychosocial aspects. Here's just an example of some of the questionnaires we ask. We have designed, some of these surveys are readily available on the REDCap library, such as the PROMIS computer adaptive surveys. So we use those. Those are based off of, those were created by the NIH to really capture physical function depression in the wider population. But we've also designed questionnaires to ask people about health behaviors, and we've looked at neurological function using predominantly the PDDS, the Patient Determined Disease Steps, and the Multiple Sclerosis Rating Scale Revised. We're measuring loneliness with the UCLA Loneliness Scale, and at week 6, we're also trying to get a sense as to people's personal network. So we use a designed personal network survey, which is also available in the REDCap shared library. And just to show you where we've recruited so far, so our reference participants and some of our MS participants come from a Genes and Environment MS study, which is a prospective study run by Dr. Dieger and Dr. Zhengxi Xia. So some of those participants, especially not in the Northeast, come from those areas, but in the Northeast, they mainly come from the sites that are actively recruiting. So as you can see in B, we have a lot of people coming from New York State, especially New York City, where we're located, and we also have a lot of people in C coming from the Pittsburgh area in Pennsylvania. I forgot to mention that the blue triangles are the MS or related disorder patients, predominantly MS, and then the green triangles are the kind of healthy reference population. And just to show you some preliminary data, again, this is all preliminary, but so far, so we, from early April to April 30th, we recruited about 1,200 patients, or 1,200 individuals, I should say. 630 have a neuroinflammatory disorder, of which MS being the most common, and the reference population were asymptomatic, or sort of a control group. Our neuroinflammatory population was older. They had more comorbidities based on the Charleston Comorbidity Index, and they had a higher BMI. They also happened to be more likely to have smoked. What we found was that actually depression was similar between the two groups, but actually the severity of depression was higher among the MS and related disorder group, and that social support as measured by modified social support scale 5-item was lower. And when we adjusted for age, race, and sex, at the height of the pandemic, there was a higher odds of severe depression in the neuroinflammatory group, and a higher odds of lower social support. And I didn't show you those slides there, but that's what we found in multivariable and regression analyses. And then we just looked at the neuroinflammatory group in more detail. As you can see here, we've recruited about 614 adults with MS. The disease duration has been pretty long, so it's about 18 years. And they tend to have mild to moderate disability based on the MS, RSR, and PDDS. DMTs were pretty widely represented, and interestingly, already the pandemic is having an impact on people, on patients' lives. For example, although 2/3 of the sample reported no change, about 1/3 have had a change in their clinic visits, and that includes either a telemedicine visit or 11% of people, their visits being canceled. And then already people are changing their disease-modifying therapy in response to the pandemic. I can't say specifically what those changes were because they're just few numbers, but we can say already that about 9% have either stopped their disease-modifying therapy or reduced their disease-modifying therapy frequency, and probably some of the frequency changes are related to infusions getting delayed. And then, as many of you know, testing in the USA has been limited, although it's picking up more recently. So we, unfortunately, very few of our patients actually had COVID-19 testing or SARS-CoV-2 testing. So we really based it on CDC symptoms, which have been updated as of end of April. But we defined it as either cough or shortness of breath or any two of the following, which include fever, sore throat, muscle aches, and loss of taste or smell. And so for our analyses, we looked at who had suspected COVID-19 based off of symptoms. And we found that between the reference group and the neuroinflammatory disorder group, there were very similar in terms of the who had suspected symptoms. The symptoms themselves were very similar between the two groups. And again, the populations are small, so some of this is due to power. But what we did find was that patients with a neuroinflammatory condition were more likely to seek guidance from a healthcare professional, and they were also more likely to have gotten emergency care, either an urgent care visit or going to the emergency room. Testing, only about 11 people tested positive, so it's a very small number. And finally, just wanted to show you the factors associated with what we call suspected COVID-19 in the neuroinflammatory group. And really, they were more likely to be depressed, and hard to say whether that's more likely a response to the infection, but hard to say. But we found that people who had suspected COVID-19 had a higher severity of their MS as by the multiple sclerosis rating scale revised. We didn't see a difference with PDDS. And when we adjusted for age and comorbidities and race, we found that MS-RSR was the only variable associated with suspected COVID-19. But again, the numbers are small at this stage. So just to show you our preliminary findings, we found that persons with MS and related disorders had more severe depression than the reference population, but they also had higher healthcare utilization. And at the moment, we found that the frequency of suspected COVID-19 was similar, but again, the numbers are small. And the neurological disease severity seemed to be the variable most correlated with suspected symptoms. And of course, this is I should advise that these are very limited results, and the limitations, of course, with the self-reported questionnaire is that people with more severe COVID-19, especially ICU or hospitalized patients, are unlikely to be participating in these surveys, and the outcomes that we're reporting are also self-reported. So these are all the sites so far who are participating in our study, and one site that's not included, the logo is a center in northern New York in Latham, who's been very helpful in providing patients. And I'd like to thank Dr. Phil Dieger and Dr. Zangshisha, who have been great mentors in this project. And if you have people who are interested in participating, here are 2 links to our surveys. And based off of if you go to these links, there's a red cap link. It will describe the survey, and there's a red cap link. And it's helpful I think it's helpful to get a patient perspective, and that's what we're really trying to understand, not just how the risk factors, but how COVID-19 is really impacting their lives more holistically. So thank you.
Thank you very much, Thad, for sharing your data and providing a new perspective to what we can learn from these registries. So we have a few minutes to take some of the questions in the chat. So one of the questions was, let's see. So somebody asked whether there's any data in the Swedish registry on COVID-19 incidence and hospitalization and ICU among rituximab-treated Swedish patients with disease other than MS, so rheumatological or neuromuscular disease. So Jan, I'm not sure whether you're still on the call or not.
Still here. Yes, I'm still here.
Yep.
The answer is no, not so far. We're trying to, so the rheumatologists have relied on performing linkages, and that is a much slower process, so they don't have data so far. We have, and that's a bit interesting for us as neurologists, we have opened up COVID modules in other part registries of our registry, which include patients with Parkinson's, ALS, etc., but we have very few patients recorded so far, which strikes me as a little bit surprising, I think.
Yeah, and so there's some of I think the German registry is not only MS, it's all sorts of disorders, autoimmune disorders or inflammatory disorders. So maybe when Kirsten Helbig will provide an update, we may see some of that. And I think there's a registry also based at Hopkins that is patient-based, but that is encompassing different disorders. So when they can present, maybe next week, actually, we will hear about that. So one question here was, do you advise patients who would like to start or not delay their treatment with anti-CD20 drugs to simply self-isolate and apply social distances, or do you recommend shielding? So question for Jan and Gavin.
Yeah, I would say that we don't know. I would say that this is a decision that needs to be based on the risk of delaying treatment, as well as a risk we don't really know yet. But it is indeed a complicated question. I can't give a straight answer. I fluctuate personally from not being so worried than actually being cautious.
So Gavin, I'm not sure whether you're still on. If you want to. So we can't hear you very well. So. So Gavin, we can't hear you very well. So maybe you want to put an answer in the chat. Maybe you can put your answer in the chat, Gavin, because we can't hear you. So we'll take a couple of more questions. So one question was about any thoughts on modifying anti-CD20 therapy interval or dose for patients older than 60. So Jan, I don't know whether you do anything special in Sweden for patients on anti-CD20 therapies.
So this is a matter of discussion, and we have no national consensus. There are some centers that do actually postpone for the time being. There are other centers amongst those, Karolinska, that has come from postponing to going back to giving regular infusions. But it's an illustration of a divided community, I think.
Okay, thank you very much. So I would like to thank Georgina, Seth, Jan, and Gavin for either presenting their data or sharing some thoughts on specific aspects of the infection and how it affects our patients, not only MS, but neurologically in general. And I will invite you to share the link of the International Women in MS website with your colleagues for those who want to listen to these sessions. And we'll see you next week if you're able to join for more information sharing. Thank you, everybody, for joining today. And so last, here Gavin said, we don't recommend self-isolation on anti-CD20. Thanks for writing, Gavin. I think your sound system was not working very well. Thank you, everybody. Bye-bye.